Okay, hi everyone, good afternoon. Thank you all for joining us today. In this session, Charmi and I will be presenting our work on drugs procurement in India, and we've co-authored this paper with Susan. Just getting right into it. Uh, just like how government builds roads, metros, and purchases drones, government also purchases drugs in India. And then there is this big aspect of problem of drug quality in the country, which many have spoken about, written about. We've been condemned internationally about it recently. And it is an issue because it can cause death, serious illness, and resistance to drugs if they don't have the potential of healing as they are supposed to have. Upfront, I would like to mention that the information that we have on the quality of drugs in the country, or how many drugs are of poor quality, this is very poor. But time and again, government goes and samples some of these. And the most recent report that is on the public domain is a drug survey that was conducted between 2014 to 2016. And there they sampled drugs across private retail outlets as well as public health facilities. And they found that the NSQ levels of drugs at the public health facilities were much higher than those at private retail outlets. And since most of us in this room have been working on it, we know that when government does procurement, there are several bottlenecks. This can be problems in the tendering, very few bidders tendering for it, payment delays, disputes, anything ranging across the contract life cycle of the procurement. So what do we do in this paper? We try to link the two. There are problems with respect to drugs in the country, but when government comes into the picture and tries to purchase drugs, are there other problems that come up, and can we identify some solutions to overcome them? Just to give a bit of a background, so the government purchase of drugs ecosystem is a little bit complex, and that's because of this. So drugs are in the concurrent list of the constitution, which means both the parliament at the center level and different states have the power to enact laws, and your procurement is done through various schemes which stems from laws and policies. So both institutions at the union level and state level procure drugs, and the primary regulation that governs this is the Drugs and Cosmetic Act, along with the Drugs and Cosmetic Rules. To add more to the complexity, public health, which includes building hospitals, dispensary, etc., that is in the state list, which comes under the direct responsibility of the state government. So that is the interplay in the ecosystem. So before we go into procurement, what are drugs? According to the Drugs and Cosmetics Act, all medicine substances that's used for treatments will be drugs, and any other associated substances will include your vitamins, gelatin, capsules, etc. And all devices used to administer your syringes, vaccines, needles, all that also come under the ambit of drugs. But for the purpose of this paper, we focus on only purchase of medicines. So when the state procures drug, what is its objective? It is to ensure timely access to safe and affordable drugs to the public. This is the mandate of most of the government schemes and institutions that procure drugs. They do this under various schemes. You have the Jan Aushadhi program, which sets up pharmacies. Then there are vector-borne disease control program, tuberculosis program. There are quite a few of those. And like I mentioned, they do it through union government and state government institutions. And they do it up until the citizen-facing public healthcare facility points. So, of course, we wanted to look at how big is government's procurement expenditure on medicines alone. While we will be able to ascertain this number for health as a whole, just to get the figures for the medicines was not easily possible from the information in the public domain. So we present some estimates. Just the context being, we want to look at the quantum of government in this space. So there's a study which shows that the number of people who avail public healthcare services from public health facilities has increased from 25% to 30% in over 3 years. This table gives you over the 6 years period from 2017 to 2022, how public health facilities has increased. So every column sees an increase. This can be your pharmacies, medical colleges, hospitals, etc. So they are increasingly constructing public health facilities. And finally, we get some procurement expenditure figure for CMSs, that's the Center Medical Services Society, which procures drugs at the union level. And they do it under various schemes, your family welfare program, non-communicable diseases, tuberculosis program, universal immunity program, etc. And you can see that the number has tripled from 2017 to 2021. Okay, so who procures drugs and how do they do it? So we just want to give you an overview of the institutional setup, just to place this in the context for the remaining part of the slideshow. Just focus on the central middle part of it. So there are two main organizations, the Medical Stores Organization and CMSs, which fall under the Ministry of Health and Family Welfare. And they are the major procuring entities at the union level. Now, there are other entities which do not fall under the Ministry of Health and Family Welfare. For example, your Indian Railways procures drugs for their employees. Defense, there is a separate arm which procures for defense service personnel and their family. We are just focusing on a couple of these. It's just representative of the whole picture. So the flow of drugs is from the procuring entities to the warehouses and then to the public facing distribution centers. The Medical Stores Organization deals with drugs only for one scheme, that is the central government healthcare scheme that caters to central government employees. CMSs does it for a plethora of schemes that we saw on the previous slides. How do they go about it? So at the first stage, the design stage of the procurement cycle, they assess demand for the rest of the year based on the previous year consumption, and then they tender through rate contracts. So they enter into rate contract with suppliers, and then on a periodic basis from lower level to upper level, they get indents. Maybe it might be bi-monthly or monthly on what is the demand required from the lower levels, and then they place purchase orders with the suppliers, and then the suppliers directly supply it to the warehouses. From there it goes down to the distribution points. And the source of funds for this is from the ministry's budget. National Health Mission funds most of the schemes, and they also get some international funding. For instance, the Global Fund funds most of our tuberculosis purchase. Okay, so quickly, the state government has a similar institutional setup. They have two models. Either they have a state medical service corporation, which is a limited liability company set up under the Companies Act, or they do it through a procurement division under their Department of Health itself. And similarly, they enter into rate contract with suppliers. They get indents for how much quantity is required from their distribution centers, and then they place purchase orders respectively, and the suppliers supplied at the warehouse level. Okay, so how does the Indian state fare when they procure drugs? So for that, we had to first define what a successful procurement is. So we are looking at it from the point of view of the citizen. What outcomes is it giving for the public? And we think any procurement exercise, especially drugs procurement, should have four main outcomes. And that is whether they are able to supply the drugs on time, whether they are able to give the required quantity, high quality drugs, and with maximum utilization of funds of the public. So do government institutions achieve this while procuring drugs? So we went through literature in the field so far and reports by the government, newspaper reports, etc., and found some evidences to show that, okay, these outcomes are not actually achieved. So there are shortages that have been studied across the supply chain, and this is across states and at the union level. You can see evidences for Tamil Nadu, Haryana, Delhi, Punjab, and so on. And MSO is the union government entity, and they also face shortages both at the distribution wellness center level and at the level of the GMST, that is the warehouse level. So I just pause for a bit. want to just look at the slide. Okay. Similarly, there's also evidence of poor quality drugs. Given the caveat that I already mentioned, the information that we have on this is quite low, but still we are able to see some evidence on how it is at all India level, whether union government procures it or state government procures it. There's still evidences of NSQ in the country. This is across states. So the best performing being Delhi and the worst performing being Sikkim. You can see that most states fall under the 7 to 17 category of NSQ levels. Finally, whether they are able to plan their expenditure properly. So in case of shortages, what happens is at the distribution center level, they go out and purchase from the local chemist. So there are two problems that stem out of this. One is that they have to pay a higher price. Rate contracts are usually tendered and negotiated and you get a blanket price. Here, because it's an ad hoc purchase, you end up paying higher price for the drugs. And secondly, the quality control is not really followed as it is in your protocol in the tendering process. So again, the impact of shortages has impact on your budget and on your quality. And on one side there are shortages, but on other side there we also see evidence of wastages due to expiry. And finally, the opportunity cost. So first we see that there are public health facilities being increasingly built, but if you don't have enough drugs or even basic drugs like anesthesia to perform an operation in your operation theater, the whole infrastructure goes to waste. Okay, so those are some instances of the problems. To sum up, we have the 4 outcomes that we think a good procurement exercise in drugs should have, and we do see that when the government is procuring, they are falling short on these 3-4 factors. Okay, so I'll pass it on to Charmi and she'll carry on with the rest of the slideshow.
Okay, so now that we've gone through the set of problems that are witnessed in the sector of drugs, our assessment is how do we start solving this problem? So we began with understanding 3 broad problems: shortages, quality, and unplanned expenditures. Quality is what we portray through an NSQ rate. Now, literature has tended to focus on the replication of certain institutional models that may have worked for the purpose of drugs procurement in the country. One example of this is the Tamil Nadu Medical Services Corporation. It's been widely appreciated for about 2 decades now, and recommended by the World Bank, WHO, all of them. So we sort of step back and try to think about whether a corporation and that model itself has any sort of direct linkage with a state's ability to contain its NSQ rates. And what we find is that there does not seem to be a clear correlation of any kind. Some states like Delhi manage to keep their NSQ rates in check even with government departments. And certain states like Gujarat and Uttar Pradesh do not manage to contain it despite having a dedicated medical services corporation for procurement. And the reason why we focus on NSQ here as the metric and not shortages or unplanned expenditure, because we would think that there's no point to giving ample medicines to citizens if they're not good quality. So that's the thinking here. So if institutional models and replicating a corporation style agency for procurement is not enough, what do we do to ensure we achieve procurement efficiency? So here we bring in an approach to government contracting that runs through 4 stages. These 4 stages are roughly planning for procurement, tendering, contract management, and closure. We understand that in India there's a limited capacity to contract, and that's why a bunch of these problems such as shortages, quality, and planned expenditures come about. And ultimately, we propose specific solutions by diagnosing every single stage of the contracting life cycle to understand what are the causes that even lead to those problems, right? So this is how we structure our framework. It runs from the first phase, that is planning, where the focus is on design and contract specifications. The second stage is that of tendering, where it's the actual exercise of releasing tenders and receiving bids, that segment. And then we move to contract management, which may also in this sector mean the supply chain itself. And then we move to closure and payments. Now, our thinking in designing this framework this way was, one, to ensure that our frameworks are always sector agnostic. So today we apply it to drugs, but we feel this framework can work for multiple sectors. And second, we wanted to understand the life cycle impacts of preliminary stages of procurement on consequent stages. So now when we look at the first one, okay, so shortages. At the design and spec stage, we find inaccurate demand assessment, which is what Pavithra also pointed out. This is a high-level quantity assessment function that a medical service corporation has to take, and this is often pointed out as a problem or a shortcoming in terms of the capacity of medical service corporations. This then also leads to delays and uncertainties in awarding rate contracts, because you often don't know how much you need, so you don't know how much you have to contract for. Second, both of these features lead to significant shortages, which also hamper the ability of distribution center level officials to place indents for further purchases upwards. And lastly, we also see excessive wastages due to expiry, because we don't have a system that formally manages stocks and when they have to go out. And there's also delayed supply and non-supply of drugs from the supplier's end, which hampers the final availability of drugs to citizens. Next, on quality, we find that the actual testing to be able to find the quantum of NSQ in your supply chain, as well as the reporting of these estimates, is very scarce. We only have one estimate to go by, which is the one we've already seen. And second, local purchases. When you purchase outside of a rate contract, you are not bound by any set of quality control protocols, etc., which you have to follow. It's all ad hoc purchasing, so you have no control over quality there. And similarly, when you locally purchase drugs, you're most often doing it at higher prices, because you again do not have a rate contract that gives you a set price at which you have to purchase. All right, so at this point, we know the problems, we know the causes for each of these problems, and we know every stage of the contracting cycle that gives rise to each of these problems. So we move to thinking about solutions. If you focus on this, you will see that most of the problems are concentrated in phase 1 and phase 3. So we pick these two phases as the key points of intervention for most of our solutions. So number 1, we come to timely supply of required quantity. That's our outcome. We believe that fixing contract conditions to incentivize more bidders and timely supply is one of the solutions. So each of these solutions will have a detailed discussion later on, so don't be confused. Second, we come to understanding information flows and how that can be improved to further improve annual estimation of quantities. We also think about how to design an inventory management system for MSCs. We also speak a little bit about building expertise to contract associated services that help streamline the procurement of drugs itself. So IT, logistics, even the next point on quality control, these are all additional associated services that can help streamline drugs procurement. On quality, we also look at prescribing minimum standard protocols. In the absence of any national sampling methodology, we feel this is one of the first steps. And lastly, we focus on minimizing ad hoc purchases, both for the sake of maintaining quality and maintaining planned expenditures. All right, so the first one, this is on contract conditions that can incentivize firms. Very often, if you do not have the right set of suppliers, or you have too few bidders who are participating itself, that severely constrains your outcomes of procurement. You may not get the best quality, you may not get the best price, and you may not even get your desired quantity. So how do you design contracts to ensure You're giving contractors what they require to be able to enter into a mutually agreeable contract. So number one is quantity assurances, that providing flexibility to price based on quality, quantity, and the length of the supply chain. And also providing some sort of a minimum and maximum range, so that the supplier has an estimate in mind upon which he has to base his price bid. Next, we often find that penalties are disproportionate. They don't quite distinguish between supply versus NSQ related defaults. So that's our next suggestion, that they should be proportionate. They should be differentiated between these different categories of default. And lastly, we find that often the drug formularies are stagnant. Revising the drug formulary, so to simplify this, moving from a crocin to a dolo can help better quality drugs and better formulated drugs enter into the market if large procuring entities are also adopting them. Second, we come to information flows that can enable an annual procurement estimation. So at this level, we term this quantity as Q1, which is the macro level quantity that a medical service corporation will contract for at the start of the year. So number one is plugging information gaps. Currently, in most medical services corporations, you do not have a consistent flow of information from distribution centers right up to the MSC headquarters, who is the one getting into the rate contracts. So this gap needs to be plugged, because this is what helps the MSC in assessing annual demand by incorporating both internal as well as external factors. Along with the previous point of revising your formulary, you consequently also need to regularly revise your essential drug list to ensure that the EDL actually reflects the true requirements of your state. And the right way to do that is to do it through a constant process of consultation with doctors and the medical community. And you can use all four of these points to then design forecasting models that can give you a near true estimate of what your MSC is going to require or what your state is going to require year on year. So establishing an inventory management system, essentially all of the problems to do with information flows, we believe can be plugged through a well-functioning inventory management system. It needs to have clear channels for communication with designated persons who must sign off at every stage of the supply chain. It should be built in with alerts that can intimate the concerned authority about drugs moving out faster than the routine. On minimizing wastage, we also think about mandating RFID tags, which can help you digitize your entire stock and hence reduce wastages. And lastly is something called a FIFO system. This is something that's been used for PDS all across the world, that it's called a first in, first out system. The stocks that go in the first must also get out the first. Next, we come to minimum standard protocols for testing. So in the absence of a uniform national methodology for sampling and testing, this is definitely a starting point. Once there is something like this, all states can be told to conduct sampling and testing at a regular schedule as well. And obviously, publishing these reports is of key importance as well, to also be able to track how your systems are functioning, right? Because you need a constant assessment of NSQ levels from time to time. Next, we come to minimizing ad hoc local purchases. So of course, we understand that local purchases happen because there are shortages. So plugging shortages is definitely the first step to addressing this problem. But nonetheless, emergencies happen, contingencies happen, and you need to be prepared for that. So one way to also look at this is to shorten your supply chain. By this, we mean that you don't need to mandate that your delivery has to go to the headquarters of the Medical Service Corporation. You can ask for your delivery to be decentralized and go directly to the warehouses. Next is that if for whatever reasons you find that you are able to get better rates through local purchasing, then you need to strategize accordingly and place a larger budget allocation for local purchasing. This is what we also see in the armed forces procurement strategies. Next is that in the event of knowing that local purchasing will eventually happen, you need to also place resources accordingly in terms of inspectors and costs for quality control at distribution center level. You need to also maintain reserves, not just for drugs, but also for suppliers. If you have suppliers who are defaulting on their quantity, you need to have backup. And lastly, to make sure emergencies are managed well and that emergencies don't become a norm. You need to define what are emergencies and then maintain funds accordingly. So far we've been talking about how to procure the drug itself and how to do that better. But now we take a step back and think about associated services that help streamline drugs procurement itself. So here we think about systems like IT, which is your inventory management system itself, the physical counterpart of that, which is logistics and warehousing and storage. And thirdly is quality control as well. Many states in India today are beginning to think about quality control through a third party arrangement where they not only have government labs, but they also empanel private labs who are roped in case of a second opinion required when they detect an NSQ. But when it comes to procuring services, it brings with it a whole bunch of risks. The capacity to design such contracts and to understand the risk allocation for each one of these services is important to build. So we come to the end of our paper, and here we just show you some key takeaways that we've gone through so far. So contrary to popular perception, we do not believe that replicating successful institutions will always deliver desired outcomes. We instead adopt a method where we go through an entire life cycle to find specific solutions. And in that exercise, we find that phase 1 and 3 emerge as key points of intervention for drugs procurement in India. We also see that the deployment of tech-based solutions such as an IMS can be useful, and hence it is critical to think about building internal capacity to procure these sort of services, and also to think about the operations and maintenance of these services, because it's not just about getting a service on board. You have to ensure that it lives across time. And lastly, in just thinking about the hierarchy of problems that we have, we feel that overcoming the problem of shortages can have snowball effects and positive effects on quality and cost efficiency. Right. So this paper presents solutions that sit within the existing construct of the life cycle, but we also step back and think about some larger questions. Do we need to start thinking about building longer term relationships with the private sector? This is what we often see in the West, where you have private hospital chains running entire healthcare centers on behalf of the government. Second, we also find that keeping the toolkit the same, many states tend to perform very, very differently on outcomes. So what is it that leads to this differential performance, right? So is it procurement laws? Is it the model of procurement being pooled or decentralized? Is it the design and nature of rate contracts itself? These are questions that we think about and will explore. And lastly, I think the point everybody would have been waiting for in the room, but is drug price regulation reform the silver bullet that we need? So things to think about, and that's where we end.
So thanks so much for this. I found this really interesting research because something similar that Ashish and I have been doing for the last 3 years. One big challenge that we saw with your approach is that you assume that there is going to be another system, which is the system we have today. we think that you should actually use the private system that we have for supply chain, which actually can take on more load. So it's actually inefficient to think of contracting out a problem that you have with government procurement. So the way procurement is working through a government system which works separately from the private system is what's causing this whole problem. So our view, when we looked at it, and I come from the private pharma market, is we don't have any of these problems in the private pharma market. So actually you should just demolish this whole thing and just treat the PHC or your Janaushadhi store as just another retail outlet, or your hospital is just another retail outlet, and let the private sector actually deliver to that retail outlet on a CIF basis. And therefore you solve all of your problems. You don't have to worry about inventory management because we have a very good way of managing inventory. You don't have to worry about shortage because we know by the day how much is sold and how much inventory is held. We know what the run rate on drugs is. We know what the batch size is. So your problem with quantity price is that we can't actually make quantities that you like. There are minimum batch sizes. So we can't give you 400 strips because the batch size is 10,000 strips. So when you go down that path of thinking quantity price and whether you can work there, it doesn't work. There are fixed batch sizes. But the difference is different entities, depending on the size of their factories, have different batch sizes. So that's where your complexity arises when you contract out and say, I want to buy X amount of a drug over a year and you will supply to me every month. Only the little guys will be able to participate in that. So then you exclude the big guys because they'll say, sorry, that's too small a batch size for us, we're not interested in it. So you have to think of that very differently. Quality is very misleading. So I don't know how much research you've done on it, but quality is an extremely misleading number here. NSQs done by government, the data that you've seen, is for the cheapest drugs because their budget is 5,000 rupees a month to test. So the inspector only has 5,000 rupees a month to go and buy product to test. So you don't expect him to actually test anything serious. He's testing cough syrup, paracetamol, ibuprofen, basic stuff. That's not the stuff that's actually being counterfeited or spurious. It's the expensive stuff that Ashish will tell me makes sense to counterfeit. You counterfeit the expensive stuff, you don't counterfeit the cheap stuff. So the NSQ data is completely wrong. It doesn't represent truly what is happening in true quality issues in the market. And you're not going to solve that with anything that we know. We're going to solve that if you test every batch. To be able to test every batch, it's actually a government lab that can do it. Nobody else has the capacity to do it. So if government really wants to procure, every state will have to build in every district a testing lab. And it's worth the money because it pays for itself. So quality is, and you can't trade quality, quantity, price in the way that you've set it out there. So there is a standard. It may not be a great standard, but we have an Indian standard for testing almost all drugs. There is a huge book, Costs of Fortune to buy. It's 50,000 rupees to buy Indian Pharmacopoeia 2014. But it has all the standards for each of the drugs. So we have a testing standard. We know how to sample. And we sample every batch. The only exception is condoms, where we sample everything. So that's the only exception to batch sampling is condoms, where we test every condom. That's how it is. So we know how to test. We know what the standard for testing is. We just don't test because it's too expensive to test. So that's your challenge with quality. I've dealt with quantity, and price is a real problem because we've discovered that the same entity for the same drug pays different prices to different people who have tendered for it. We have ESIC notification from the most recent one from 2017 to 2021, no, 21 to 24. The current ESIC procures drugs at different prices from different people in the same tender. And that is just ESIC. And we've done a comparison of price between CGHS, ESIC, Janaushadhi, Tamil Nadu, and found all different prices. So we can't even agree a price. Government hasn't found one price for one drug that it is paying for from the same person it's buying. So if you want to simplify, I think the solution is there. Can we get government to agree that we'll pay one price to the one person who we have selected for all the contracts that we are giving out? I mean, that's not a hard thing to do.
Government is not monolithic. There are many contracting
And we find it strange that government's not able to use
no, it is sound and appropriate
to
that a
pay 10
union-
times the price.
that a union government is different from a Maharashtra government.
No, we know
A
union
Maharashtra
government.
government is different.
No,
from a
Ajay, I'm saying union government, CGHS, ESI, all union government schemes.
I just want to say there are trade-offs. How much centralization do you want? Do you want AIMS to do it on their own? Do you want a central procuring organization? This has trade-offs. This has consequences.
I agree. But there's no justification for one government agency paying 10 times the price that another is. Whatever may be the trade-off, 10 times. No, it's a national price. It's a national price. So I've taken that into consideration. I agree with you. Then you should not have a national price. I agree with you. But here we have a national price, which is 10 times across those three schemes. So I can't find justification for it. And one of our suggestions was not to have one price, is to actually have a CIF price at the location.
So carefully. First, I agree with you that if there's a 10x difference in two different procurements, it's odd and something is wrong. It's a correct narration that there is a malady.
Yeah.
But there is no ready solution because
I'm not
the only
suggesting.
way to create a construct where you're guaranteed one price is to unify the procurement, which has many other consequences.
I agree.
Okay. Now, when you have two different procurements that are running, they will always have a slightly different price. Now, you can say if they run well, they'll end up with a similar price. That's a correct statement. But there is no way to force these to become one. Either you're running separate procurements or you're not. And generally, big, monstrous, centralized things in India have worked badly. Okay, it's better to have more energy all over the system, where there are many pieces. Where Navy is different from Air Force. If you force everybody to buy together, it introduces a different set of maladies, and it has its own consequences. So, if your position is, look, I see three different agencies of the union government with landing at very different prices, that shows that something is going wrong. I'm with you, but it doesn't readily suggest an answer. It means all the three need to be fixed, and fixing them is complicated. There's no ready answer on how to fix them.
I'm just saying, I'm a response to this, which is that you're seeking one price per quantity and quality. I'm saying no entity, a procuring entity for drugs, has achieved that. In fact, the problem is that they can't agree this even within their own system. So for ESI, we have two different prices. It makes no sense. And the lower price is to a greater brand. So we picked Teneligliptin, brand I know well. The leading brand is by Glenmark. It's called Zyton, 36% market share, and by far the leading brand. Everybody else is in small single digits. Gets a lower price from ESI than some unknown United Pharma, which doesn't even figure in the top 100 brands. Those are the challenges that we see when you go off and procure, not having a clear policy on how you're going to procure. So on one hand, we have that kind of drug procurement. On the other hand, NACO, which procures condoms again, and is funded by the Global Fund, so it's not even our money, has a different way of tendering. The way it tenders is asks people to submit bids and then allocates amongst those who are tendering quantities based on a price. So everybody gets to participate on a price that is the lowest price, and then they can go out and say, okay, we'd like to still win at whatever price you agree, and then they go down that path. So we have different ways of actually arriving at price and arriving at who's going to supply. So it's quite a complex thing when it comes to this. The one thing you haven't dealt with is the essential medicines list. So each of these bodies has a different list. So we can't agree what is essential. No, said I'm not talking states. Let's not go down the states. I mean, that's a big mess. You have 30 different lists. In the center, we don't have one list. So CGHS has a different one. The armed forces have a different one. ESI has a different one. The railways have a different one. So even within central government, even within PMJ, you just compare these 5. They can't agree what is an essential medicine.
What is that? How different are they? Like 80%
same, 20% same?
No connection.
And what are the consequences for the purpose of procurement?
So the difficulty we have is that what you get under one scheme is not available under another scheme. So the same hospital, so the hospitals are all, let's assume that the same hospital is empaneled under CGHS, ESI, PMJ. Depending on who goes there, they will decide for the same ailment. They will decide, I cannot give you drug X, I can only give you drug Y. So depending on the scheme and what is covered in the drug, your treatment then gets adjusted to it. It makes no sense.
A drug formulary being vastly different across different agencies?
Yes, and there's no basis for it. So if you go for the WHO list, which is a very political list, there is a list. We take that list, but we use it for price control, not for actually supplying drugs.
So we should actually mention the formulation as opposed to mentioning the drug.
The drug is just the name, right? So it doesn't matter. 10 ligaptin. So forget brand, forget everything else. We don't get the same list of drugs. So you have 3 in the CGHS. Yes, the entirely different list. So you have 6 gliptins in the CGHS. You only have 1 in ESI. Makes no sense. It's actually the cheaper one you can get. So there's no rationale behind how we go about this process.
So one of the things that we struggled with when we try to work with this paper and this problem is that we know there's a whole lot of thinking on problems in drugs regulation. So some of the stuff about drug formulary pricing, it actually sits in the regulatory part of it. We are trying really, really hard to focus on the procurement process.
Exactly.
Given the regulation. And I agree with you, right? Our challenge really sitting on the outside is to say that even if we had to look at just the procurement process and see where the failures are coming up, we have a great disadvantage because we see, unlike you, we do not get to see any data whatsoever.
Yeah.
So we are really literally scrambling in dry earth to get some evidence, right? And shortages are all from desk research, right? Other people have done these one-off research pieces that says, yes, we found this, so or CAG reports, which is not once again consistent or regular.
Yeah.
So knitting together a story about what are the problems in drug procurement, leaving aside that drug regulation is completely fractured and broken in this country. So
Correct.
Given the fractured and broken drug regulation,
that's why I haven't gone down regulation. I have not gone down regulation at all.
But one of the things that we wanted to ask is things like pricing or the definition of what medicines fit under the essential medical list, medicines list. We think that is more regulation as compared with procurement. Is that correct or not?
No, because the essential medicines list has no real good basis in science.
Agreed.
That's our problem, right?
So it's a political problem. Somebody chosen has put it down.
In WHO, and for a different purpose. That purpose is for health security. It is not going to solve your health problem. It says these are the essential drugs you need to have as a basic list. I'll give you a good example. And the example we've taken to research in our paper is sofosbuvir. I know it doesn't mean anything to you people, but in 2015 it was the only cure for hepatitis C. And the alternative to that was a liver transplant. So Gilead, which brought the drug to market, actually didn't invent it. Somebody else did, acquired a company for some 12 billion, and therefore had to make money on that one product. So it priced it at $1,000 a pill. And so the treatment was $84,000. And they priced it because the alternative was going to be a liver transplant that was $200,000. So you're getting it cheap, right? Now, under the WHO essential medicines list, it wouldn't make it. It wouldn't make it to any of these lists because it's a patented drug. And patented drugs are excluded from DPC or excluded from essential medicines. So even if it is essential to save lives, it won't make it to this list. So we can't go down that list and say how it will work. Now we solved that problem eventually because we fought with them, and I was at Cipla and we fought with them and we got the whole thing. Now it was available for $200 instead of $84,000 at $200. It is on the CGHS list, but not on PMJ. So a bureaucrat will get it, but the poor guy who can't afford it will die, or can buy it at 9 lakhs of rupees.
And the bureaucrat will get it at 900 rupees.
Exactly.
The private market is 16,000 rupees.
So we're finding that it's a procurement problem. It's not a drug regulatory problem. We have the drug, it's available in plenty in India. 6 Indian companies make it under license, and yet we can't get it. There's an easy way to fix it, which is, even if it was a patented drug, my suggestion a long time ago was that the government can procure it in a way that you tender out for that drug. If the patent owner tenders for it and is the lowest bidder, there's no problem, they get it. If the patent owner does not tender or is not the lowest, they just license it to whoever is willing to produce it. And that's permitted under both the Patents Act and TRIPS. And therefore, you'd get Indian organizations tendering for a drug which is patented, but is going to be in government use. And the patent owner gets a royalty of, say, 5% on it, which is the international standard for royalties. And we get the drug in the public market. So we fixed even that problem in the model. So procurement can fix a lot of problems without touching regulation.
We should discuss this because this is something that we thought was out of our ambit in procurement. But
So the generics, your big problem here is actually quality. It's because of the counterparty. So if you look at the list of people who tender, it's some Prakash and Company, some Ajay agencies, people like that, who have absolutely no standing in delivering product. And therefore, you're likely to get poorer quality even if you do the same bad sampling, because you're consistent in the bad, right? So you will get.
so here's where we thought that actually this is true. This can be procurement because it's about criterion of who makes the cut in terms
Exactly.
of vendors. You are empaneled.
So he's saying the batch that they're asking is so low. So we don't even create such.
So, but that is the empanelment criterion in the procurement process. So that fits with us.
Yeah, so I'm not going down regulation. So my response is, you've got a model, and my solution I'd suggest to you is just go and add this to the current retail model and deal with all the supply chain, let them deal with it. Let the price be CIF, so we don't have to deal with what kind of a defect it is. Is it a transportation problem? Is it a storage problem? Is it a coloring problem? Is it packaging problem? Secondary packaging, primary packaging. Primary packaging in eye drops is different from primary packaging in calcium tablets. So, if you have a problem here, the whole thing goes. If you have a problem there, you can actually look at it. So there isn't a simple way of dealing with it in government, whereas there is a well-established way of dealing with it in the private sector. We've dealt with it for many years. It keeps getting better, and we can deal with all these challenges there. So our model was actually to say, get rid of this whole thing and buy the end product at the end user, and the system which is set up by the private entities, we can actually use, we can enhance by saying we will do quality checks per batch.